Great. Well, thanks for the invitation to present to you on two different but overlapping topics, capacity constraints and geographic variation in access to lung cancer screening. So here was an interesting diagram that I found by Field et al. In the UK, looking at the evidence on lung cancer screening implementation, on all different components of lung cancer screening implementation. And the only aspect of this that got a code red by them, meaning that there is very limited evidence on this topic, is recruitment of hard-to-reach populations, which will be part of my topic of my talk. And as I'll show you, I only identified 4 really sort of in-depth, sort of solid studies trying to look at hard-to-reach populations and capacity for reaching them. So definitely there's more research needed to avoid disparities when we try scaling up lung cancer screening, particularly, as others have mentioned, as smoking burden is concentrated among rural, low-educated, low-income populations. If we really want to get screening right, we have to make sure we can reach those people. So we're going to be talking about this, I think, in the next session. Components of high-quality lung cancer screening by some of the specialist societies have been sort of forwarding these. I'm not going to go over these, but these should give a sense of maybe some of the types of capacity. Oh, gotcha. This should give a sense of some of the kinds of capacity that would be needed to make a high-quality lung cancer screening program. And there are concerns among many that have been voiced about the ability of community providers to really meet all of these criteria to provide a high-quality program. In the extreme, some may wish to restrict access to high-quality screening programs only. We saw the quote by the ACS that if patients are not willing to travel to a high-quality program, then they probably should not get screened. And I think, riffing off some of the comments that were made by Chris and Douglas, you know, we may have a sort of pushback against that from the perspective of potential disparities. If we're going to restrict access to only selected programs, it's almost inevitable, I think, that take-up of screening will drop, and in particular, I think, among those hard-to-reach populations. So there's going to be this trade-off between high-quality comprehensive programs and access, at least a potential trade-off that comes out of that. And depending on our priorities, maybe quality versus equity and how much weight we put on each of those, we may consider some flexibility in whether we really need every component of a comprehensive high-quality screening program to be accessible by all patients, or whether we might be willing to make some allowances for the hard-to-reach populations. And I'll be getting into some ways that that might be possible and necessary. So there have been some surveys on capacity for lung cancer screening. Eberth and Searcy, Boisel et al. They have done surveys of mostly academic lung cancer screening programs. And these are very informative. But on the other hand, they don't really include a lot of the community providers that might end up providing services to a lot, maybe a majority, of patients seeking lung cancer screening. So I think it's necessary to go beyond this and to try to really get to the universe of potential providers of lung cancer screening. And so I'm going to focus on 4 studies of the nationwide capacity constraints and geographic variation that tried to really look at a nationwide study of capacity and how that might affect access to screening. First is a study on capacity in comprehensive lung cancer screening centers by Eberth et al. Then my group has 2 studies on radiologist capacity across the country and CT scanner capacity across the country and how that might lead to disparities. And finally, a study on capacity constraints in thoracic surgery. These were the only 4 that I could find that really did a careful empirical analysis of this topic. I think the next steps beyond this type of research is once lung cancer screening starts to scale up, then would be to estimate the impact of capacity as it's spread across the country on use of screening, on stage of diagnosis, if we expect an uptick in the cancer staging due to lung cancer screening. That would be the next step in this research agenda. So here's sort of a picture of how a lot of this research sort of moves forward. There's an estimate of the potential demand for lung cancer screening, essentially where the smokers are and how many there are across the country. And then there's also an estimate of the potential supply for lung cancer screening through a variety of measures. and try to get sort of a measure of how much demand might exceed supply, leading to capacity constraints, and how that's distributed across the country. To get at smoker counts, there are a couple of public use data sets, the BRFIS, the National Health Interview Study, that can help us get estimates, not super precise, but estimates of sort of eligibility for lung cancer screening, at least the smoking history component of eligibility in different parts of the country. And then for capacity measures, there are all sorts of different data sets to study different potential pieces of the capacity puzzle. So most broadly, comprehensive lung cancer screening facilities. The Lung Cancer Alliance has centers of excellence that they've defined that provide this screening. The American College of Radiology now has an accreditation program for lung cancer screening programs. And then we can get more disaggregated, more of the basic components of lung cancer screening programs, counts of radiologists, counts of thoracic surgeons, of CT scanners, and where they're located around the country. And then the CDC and other public health institutes engage maybe to some degree in lung cancer screening so far, but definitely to a great degree in programs to promote, for example, breast and cervical cancer screening among vulnerable populations, engaging in broad anti-smoking efforts around the country. And we could see those as potentially being able to sort of morph into extending and promoting lung cancer screening as well. So we could judge those as potential measures of capacity of public health systems to promote lung cancer screening going forward. No studies have been done doing that yet, but that's, I think, a possible next step. And the final goal of all this is really to sort of put supply and demand together and come up with heat maps of potential capacity constraints, as you see in these maps right here, identifying areas that seem to have capacity constraints, risk factors of areas obtaining capacity constraints, and therefore using that information to then target those areas to beef up capacity to hopefully alleviate disparities in access to screening. So the first study I want to talk about is this one, Eberth et al. On comprehensive lung cancer screening centers. This was done in March of 2014, and they identified 203 lung cancer screening centers around the country. That comes out to 0.3 centers per 100,000 people age 55 to 79, where if you do some back of the envelope math, comes out to about 65,000 USPSTF eligible screenees per center per year. So for the docs in the audience, I mean, no problem, right? Just roll up your sleeves and 65,000 patient throughput per year, no problem. Actually, clearly a lack of capacity in terms of screening programs, at least in March of 2014. And we see huge variation across states in this. 11 states had no screening centers that they could identify. Rural areas lacked this the most, and 11 large cities, however, of 1 million people or more, also have no screening centers. We see that the biggest areas of missing centers are in the South and the Mountain and Upper Great Plains states. Now, the centers map up somewhat better. The centers map up somewhat better to where the smokers are located. So the darker black areas of this map show higher areas of smoking prevalence around the country. And we see an agglomeration of red dots in the Midwest, near where a lot of the smokers are, and in the Southeast, mapping where the need seems to be. On the other hand, we also see a great density in the Northeast Acela corridor, and also on the West Coast, where there are quite a few fewer smokers. So not quite matched to where the need is. Now, 2 years later, after the study's been done, I counted last night, and I found there are now 427 Lung Cancer Alliance approved centers and nearly 1,400 American College of Radiology accredited centers. So there's been a huge increase in 2 years in the number of comprehensive centers providing these services. This map would look very different, and our estimation of sort of lack of capacity should be different now. So I think there's a real opportunity for research to update those earlier findings. But still, I think this type of map illustrates the trade-off that I pointed to between access and really sort of insisting on everyone being seen in these comprehensive programs. And I think that motivates some of the next studies, which are studying the spread of more basic components of screening, which may be more dispersed around the country than comprehensive centers alone. So here's a study that my group did on radiologist capacity, and we took health service areas as the geographic catchment areas for cancer care. The first thing we did is we estimated the total annual imaging procedures in each HSA, not just CT scans, but MRIs, X-rays, ultrasounds, et cetera, using a variety of sources and some somewhat strong assumptions. The next step was to estimate the incremental scan interpretations that radiologists would need to do in each HSA from implementing lung cancer screening and doing all these extra CT scans at the rate that they were done in the NLST. And we assumed that we would scale up lung cancer screening to 75% of the USPSTF eligible population. And what we found was a mean of a 4% increase in total scans that would be done in HSAs due to implementing lung cancer screening. So a moderate amount. Now, this also does not include 127 HSAs, which had no scans and no radiologists that we could see at baseline. And so they have basically an infinite percentage increase that would be required if they tried to implement lung cancer screening. So definitely those areas would be capacity constrained from trying to do that. We then tried to set some thresholds. Okay, what 4% is the mean. What would be a threshold of sort of this place really is doing a big increase that would be a constraint on their capacity? And so we set a range. There's no sort of science to this, no standards in the literature on this. So we set a range of between a 5% and a 25% increase in scans that we would define as a capacity constrained area. If we use the 5% range, we find that over 1 million eligible smokers, or over 10% of the USPSTF eligible smokers in the country, reside in HSAs that would face a greater than 5% increase in scans from implementing lung cancer screening. If we use the more restrictive 25% increase, we find 136,000 smokers, a bit more than 1% of the total population that would be in those HSAs. Now, those are moderate amounts. If we look in terms of the proportion of HSAs that would be affected, between 16% and 36% of geographies in the country are in areas that are defined by these different ways as being capacity constrained. So quite a few. Now, if we look at this geographically, spread across the country, and now the darker green areas are the more capacity constrained areas. The darkest green is the over 25% capacity area. And so we find sort of the biggest constraints are here in the middle of the country, in the Great Plains states. Again, similar to the earlier map. The lowest constraints are in the west. And we looked at several predictors of capacity constraints, rural HSAs, HSAs that have a higher percentage of smokers in their population, and among the smokers, HSAs where more of the smokers are Hispanic and low income were at higher risk for facing capacity constraints. So I think this analysis suggests that these geographic disparities that are the focus of my discussion may actually contribute to additional racial and income-based disparities because of where these different population groups live around the country. Here's another study that we did, and not yet published, but we've been working on it. And this asks a simpler question. It's about CT scanners, and we ask how many smokers live in areas with no CT scanners. And what's really necessary for lung cancer screening is a multi-slice CT scanner. In particular, over 16 slices is best. Now, our data can't measure how many slices there is, but we can tell if it's a multi-slice or if it's a single-slice CT scanner. And actually, some places still just have single-slice CT scanners. And first, we looked at the HSA level. We found that 33 HSAs out of about 800 in the country have no CT scanners. 67 HSAs have no multi-slice CT scanners. This only represents about 1% of the population. So from this perspective, it doesn't seem like a huge problem. But if we go to a narrower geographical area, the county, we find some more interesting results. Here's a map of all 3,000 counties in the country. See if you can count them real fast. And so again, now the darker green is the more capacity constrained area. The darkest green has no CT scanner at all. The middle green has no multi-slice CT scanner, and the light green does have a multi-slice CT scanner. And the patterns that we see, again, are pretty similar as before. Great Plains and mountain counties are the most likely to be darkest green. Also, rural and low population areas are more likely. Now, you do see some dark green areas in the east, although it should be pointed out these counties tend to be smaller in the east, so it's probably easier for those patients to travel to a nearby county that does have a CT scanner if theirs doesn't have it. But anyway, we counted up and we found that 32% of counties have no CT scanner. That represents 8% of all the eligible smokers for lung cancer screening. And 43% of counties, nearly half, have no multi-slice CT scanner, including 1.1 million eligible smokers. So potential barriers to access to CT scanners. Here's the last study I want to talk about. It's from a Canadian group that looked at thoracic surgery capacity constraints. And what they did was they project thoracic surgery workforce requirements in Canada from lung cancer CT screening. They ran a microsimulation model of smoking history and lung cancer incidence. And highlighted in green, I want to point out something I want to bring up in the conclusions. They project that the smoking eligible population peaks in 2017 and then will decline by greater than 50% by 2040. They find that cancer diagnoses, maybe not surprisingly, increase. There's a shift to earlier stage cancers. And in terms of the thoracic surgery volume, it will go up by 24% by 2020 and then gradually decline. Now, this chart shows the impact of medical education policies on these potential capacity constraints. Canada, being a smaller country and not so specialist dominated as we are in the US, has only in the order of 4 to 5 or to 6 thoracic surgery graduates per year. But this makes a huge difference. If there's only 4 graduates per year, there will be an increased workload per surgeon of 50% by 2030. If they increase education pipeline up to 8 graduates per year, there's almost a negligible increase in workflow for those thoracic surgeons. So translated to the US, where we have a population that's about 10 times larger, then that means the difference between 40 thoracic surgeon graduates per year versus 80. Something that I'm guessing would probably be manageable if there were clearly a need for extra thoracic surgery graduates in the US. And I'll just point out, this study did not look at the geographic distribution. They just looked at the nationwide needs for thoracic surgeons. So I want to just conclude with some policy considerations. The summary of these results maybe is there are potential geographic access problems, and largely in rural areas in America. And as I stated at the start, I think this is very important to consider, but I also think what are going to be the costs of trying to deal with this issue? And I worry a bit about that. And a way that I propose we might want to think about this is maybe different levels of evidence are required for different types of policy decisions. We've seen the considerations that went behind the MedCAC report to Medicare, behind the USPSTF deliberations. In terms which in the end implied sort of coverage or non-coverage of lung cancer screening. And those deliberations centered really on do the benefits exceed the harms of lung cancer screening. But now we're talking about if we really want to achieve universal, equitable screening in all areas of the country, that's going to involve sort of big investments to add CT scanners, to add radiologists, to somehow get the thoracic surgeons out to rural areas to sort of achieve the capacity needed for the smoking burden that exists in those areas. And I think that requires a higher bar of evidence. It would require that for the foreseeable future, CT screening's expected benefits exceed the expected harms, and perhaps are also cost effective. And I'm not sure if I believe that second statement and policy choice, but it's certainly debatable for a couple of reasons. So blood-based tumor-free, cell-free tumor DNA tests may be coming up soon for screening. We've already seen the first FDA-approved cell-free DNA test for lung cancer for personalized medicine in lung cancer to determine the use of targeted therapies. That's been approved by the FDA. We've seen recently in colorectal cancer, the first blood-based omics screening test, screening for colorectal cancer. That's been approved by the FDA, and I believe the USPSTF just recently condoned it as a viable method of screening. And now we have companies spending hundreds of millions of dollars to develop a pan-cancer, cell-free tumor DNA blood test to screen for all cancers. Now, there's no evidence that this is going to work, but people are spending a lot of money and believe that it could work. There's at least the potential that this could come out, and I believe that that would be much easier to grant access to these hard-to-reach populations using that sort of screening test than probably through the existing CT-based screening. As well, as we've talked about, personalized risk-stratified screening may further reduce capacity needs in the future. And finally, like I said, projected drops in screening-eligible population. We've seen a 5% reduction in smoking rates in 7 years, incredible drops in smoking rates. We have, from some models, a 50% decline in projected numbers of screening-eligible smokers in the next 16 years. That will require a lot less capacity to screen all those people than it would right now. And so, all things considered, the demand for CT screening in the future, probably, not for sure, but probably will be lower than it currently is, and that we think it maybe will be now. And so I might suggest that to avoid overinvestment in capacity, to try to deal with these hard-to-reach populations, let's go with some small-scale, frugal approaches towards serving them. For example, initial diagnosis by community-based CT scanners, primary care docs, and radiologists, only with referral to comprehensive screening centers if there was a suspicious nodule finding in the initial CT scan. And some pilot projects in trying to use labor-saving devices like teleradiology, computer-aided detection, volumetric nodule analysis, and using primary care docs to do interpretation of scans to improve access with minimal new workforce capacity requirements and programs. Those are all my thoughts. I'd like to thank the NCI for financial support and my collaborators as well.